Hi there, my name is Demirjian. This video is about managing severe hyponatremia in a patient who is to be started on continuous hemodialysis. Welcome to Kidney Guide. An elderly patient presents with decompensated heart failure, and her labs show kidney failure complicated by hyponatremia, low sodium, hyperkalemia, elevated potassium, and metabolic acidosis. And she is 6 kilos above her baseline weight. The decision is made to start continuous dialysis given her tenuous respiratory status. Central pontine myelinolysis, or osmotic demyelination syndrome, is a rare but serious complication that can occur with rapid correction of chronic severe hyponatremia. Typical findings on MRI is symmetrical high intensity seen at central pontine region with sparing of descending corticospinal tracts. This is also known as the trident sign. In a one-compartment model, which views the human body as a homogeneous unit, elimination or clearance of a substance changes based on its concentration. This is in contrast to zero-order kinetics, which follow constant clearance regardless of concentration. With integration of both sides of the equation over time, followed by log transformation, you can solve for the concentration of the solute at any point in time if you know the starting concentration, clearance, and volume of distribution. And when you solve for the change of the solute concentration from baseline, divided by the difference of baseline concentration from that of dialysate, you can estimate the reduction ratio by 1 minus e to the power minus kT over V. And since sodium behaves similar to urea, we can substitute in sodium and predict the serum sodium concentration at a time in the future by knowing the initial sodium, the sodium in the dialysate, dialysis intensity, and volume of distribution. You can also flip the equation to calculate the dialysis intensity or effluent rate to achieve a target serum sodium. In a similar fashion, you can predict the free water infusion rate to achieve and maintain the target serum sodium for a given dialysis intensity. Having reviewed all of that, you'll be happy to know that all you need to do to get some quick answers is log in to kidneyguide.org and click on the calculator section. In the first calculator, you plug in the patient's serum sodium, 110, your goal increase in the next 24 hours, 120, patient body fluid volume, 31, and assuming the dialysate sodium is 140, then your effluent rate should be 520 milliliters per hour. Since that's too low, the other thing you can do is lower the dialysate sodium concentration. Then for effluent rate of 1.4 liters per hour, the dialysate sodium need to be changed to 125. If adding water to dialysate bags is not what you want to do, then you can opt for D5 water infusion to the patient directly. For the same target of 120 and effluent rate of 1.4 liters per hour, you will need to run D5 water at 200 mL per hour. The last calculator helps you figure out the 3% hypertonic infusion rate to achieve and maintain therapeutic hypernatremia, or avoid rapid correction in a patient who presents with elevated serum sodium levels. You will need the target sodium and the effluent rate. 160 and 1.4 liters per hour in this example, which will need 3% infusion running at 75 mL per hour. Hope you enjoyed the presentation.